Hello, I'm Dr. Daniel Kuritzkes, and I'm going to be providing an update on remdesivir. What do the clinical trials tell us? These are my disclosures. Remdesivir, as you know, is an RNA-dependent RNA polymerase inhibitor with in vitro activity against a range of viruses, including Ebola, SARS, MERS, and SARS-CoV-2. This graph on the right-hand side here shows the in vitro inhibition curve demonstrating an IC50 of just under 1 micromolar. Remdesivir has been studied in clinical trials against other viruses, notably Ebola, where it was shown actually to be inferior to broadly neutralizing antibodies. But in animal models with other coronaviruses, including MERS, remdesivir was shown to be effective in both murine and non-human primate models. It's also been shown to be effective against SARS-CoV-2 in the non-human primate model. These data here show reductions in the level of SARS-CoV-2 recoverable from various samples in the primates, and shows the lung pathology with relatively well-preserved histology in the treated animals compared to the very congested and highly inflamed lung parenchyma shown in the controls. Numerous clinical trials have now been completed and reported for remdesivir in patients with COVID-19. The first of these was a randomized clinical trial conducted in Wuhan, China, was a double-blind trial with randomizing patients 2-to-1 to remdesivir versus placebo. And these were all in people with severe disease. The time to clinical improvement at day 28 was the primary endpoint, but the study was brought to an end prematurely because as the epidemic came under control in Wuhan, they were unable to fully enroll the trial. So they only ended up with just under 240 of the 450 or so planned participants, substantially reducing the power of the trial to find any evidence of benefit. And as you can see from these curves, there really was no difference in the cumulative improvement rate when remdesivir was compared to control. Notably, there was also no difference in the rate of virus clearance, whether looking at the upper respiratory tract or in samples from the lower respiratory tract. Subsequently, a large open-label experience with compassionate use remdesivir in patients with severe COVID-19 was published in the New England Journal of Medicine. Now, this is not a randomized clinical trial. These were all patients who received remdesivir through compassionate use. And what you see in the first panel here is the cumulative incidence of clinical improvement with about half of the recipients improving by around day 16 or 17. This was faster in people who were receiving non-invasive supplemental oxygen compared to those who were receiving invasive, mostly mechanical ventilation, and was also notably faster in younger people compared to those who were over age 70. Now, when these data are compared to contemporaneous data with people not receiving remdesivir or people in control arms of other studies, it appears that the rate of improvement and the proportion improving, particularly among those receiving invasive ventilation, was much greater than what was then the currently observed response. However, these are not randomized patients, and so there's only so much that can be concluded from these data. So the first really positive data for remdesivir come from the ACT-1 study. This was a multi-center randomized double-blind trial conducted under sponsorship from the NIH. And this study enrolled hospitalized adults with COVID-19 pneumonia. They were randomized equally between remdesivir and placebo, the primary endpoint being the time to recovery within 28 days. The preliminary analysis was conducted after just over 600 participants had achieved recovery. And about 80% of the participants had one or more other medical conditions, so they were at risk for severe outcomes. And about a quarter of them were either intubated or on ECMO at entry. So we're really a very sick patient population. What you can see is that overall, remdesivir resulted in a reduction in the number of days to recovery. This was about a 3 or 4 day reduction on average, roughly a 30% reduction in the time to recovery. And that difference was most pronounced in patients who were receiving supplemental oxygen, but was not seen in people who required high flow or non-invasive mechanical ventilation, such as BiPAP or CPAP, and was not seen at all in patients receiving mechanical ventilation or ECMO. There was also no significant difference in the time to recovery among patients who were not receiving any supplemental oxygen, although numerically it appeared that the time to recovery was somewhat faster with remdesivir than with placebo. Now, if we look at different subgroups, you can see that the recovery rate ratio favored remdesivir not only in the study overall, but really across all the categories of subgroup, whether looking by geography, by race and ethnicity, by age, although clearly the youngest participants had the greatest improvement on remdesivir compared to older participants, by gender. And here, importantly, what we see is that people treated earlier with symptoms of under 10 days of duration had a significantly greater improvement with remdesivir, whereas those who were treated after more than 10 days of illness, that confidence limit crosses 1, so does not achieve significance. And then looking by a baseline ordinal scale, that is just how sick people were at the outset, we see again what was reflected in those Kaplan-Meier plots, that people receiving supplemental oxygen had a significantly greater recovery rate ratio compared to placebo, but those differences were not significant among those not receiving oxygen, and really were essentially 1, meaning no advantage if they were on mechanical ventilation or receiving high flow oxygen. We look quickly at the safety and toxicities of remdesivir. We can see that there were really very similar rates of grade 3 or 4 adverse events and serious adverse events in the study. In fact, actually for serious adverse events, the rates were higher in the placebo group compared to the remdesivir group. Now, the next set of studies to look at are the SIMPLE trials, and there were 2 of these. They were both sponsored by Gilead. One was done in patients with severe disease, and those were people who had an oxygen saturation of 94% or less, or required supplemental oxygen to maintain an SpO2 of 94%. They had to have documented SARS-CoV-2 by PCR, evidence of pulmonary infiltrates, and they could not be intubated at the time of enrollment. The study randomized patients to receive either, so these were people considered to have severe disease. And this study randomized people to receive the same daily dose of remdesivir, but for either 5 days or 10 days. There was no placebo control in this trial. And the endpoint was clinical improvement, defined as an improvement of 2 points or more on this 7-point ordinal scale, ranging from hospital discharge being the best outcome to increasing levels of oxygen support, ultimately with death as the worst outcome. And patients achieved clinical recovery if they no longer required oxygen support or were discharged from the hospital. Just quickly to look at the baseline characteristics, note that a large proportion of the participants had 1 or more coexisting conditions, including diabetes, hyperlipidemia, hypertension, or asthma. Roughly 30%, the median body mass index was just under 30, meaning that this was a largely obese population. About a quarter of the participants were receiving either non-invasive ventilation or high flow oxygen, and roughly 55% of them were getting a low flow oxygen. And then the median duration of symptoms before the first dose was 8 or 9 days. Remember, in the other study, we saw that getting remdesivir at 10 days or less of symptoms made a difference. Here are the primary and secondary endpoints. Looking at overall improvement in clinical status, there really was no difference between being treated for 5 days or 10 days. Also looking at mortality, which was a component of the clinical status endpoint, the proportion of deaths was 8 and 11%. Time to clinical improvement was not different. Clinical improvement at day 14 in terms of the proportions. There was a numerical difference favoring the 5-day group, but that did not achieve statistical significance. Likewise, time to recovery was similar between the groups, and the proportion experiencing clinical recovery is almost identical to the proportion achieving clinical improvement, again, not reaching statistical significance. Now, the data from this study were then compared to a contemporaneous control group of patients being treated at centers not participating in the Remdesivir trial, but receiving the standard of care. And so they took all the participants in the severe trial, in the simple trial in the severe cohort who received Remdesivir and compared their outcome to this group of people in these selected centers around the country who were not getting Remdesivir and looked at their outcomes. And what they did is looking at recovery at day 14, you can see that roughly 3/4 of the Remdesivir cohort had shown recovery compared to just about 60% in the non-Remdesivir cohort, and that was statistically significant. And if you looked at mortality, there was about a 7.5% mortality in the Remdesivir cohort compared to 12.5% in the non-Remdesivir cohort, which was also statistically significant. So these data are suggestive of a clinical benefit and suggestive of a mortality benefit in patients with severe disease, but it's not a randomized clinical trial. So the second simple trial was done in patients with moderate disease. Now this was a 3-arm double-blind placebo-controlled trial. It again compared 5 days versus 10 days of Remdesivir, but also had a standard of care comparison group. Again, entry criteria required the presence of SARS-CoV-2 by PCR, but here to be defined as having moderate disease, you had to have an oxygen saturation of greater than 94%, not requiring oxygen to maintain that. And initially, 600 participants were enrolled into this trial, with the primary endpoint being clinical status at day 11. The 5-day arm showed greater clinical improvement as compared to standard of care, with an odds ratio of just under 1.7, which was statistically significant. Well, if we look quickly at the baseline characteristics, just to compare these patients or participants with the severe trial, we can see that once again, the median BMI was pretty close to being obese, but just a little bit leaner. We see that about between 12 and 18% required low flow oxygen, but 80 to 85% were not requiring any oxygen at all, in keeping with the entry criteria. Once again, somewhere between 15 and 60% of the participants had one or more coexisting conditions, including cardiovascular disease, hypertension, diabetes, or asthma. And this group also had about 8 or 9 days of duration of symptoms before being dosed with Remdesivir. Looking at more detail at the outcomes, and here this ordinal scale is color-coded for you, with the darkest color being the worst outcome, death, and the lightest color being discharge. You can see that overall, the vast majority of participants did get discharged, because this was not such a sick group to begin with. And at day 11, what we see is that the 5-day group, there are more discharges overall. The distribution of endpoints is weighted towards a more favorable endpoint. And so this achieved a statistically significant difference compared to the standard of care. But the 10-day arm did not, and that's a little puzzling, because certainly these two outcomes ought to be more similar to each other. And so why one is significantly better than standard of care and the other is not requires some further analysis. If we then look at day 14, we see that both remdesivir arms achieve significance, but at day 28, it's flipped. The 10-day arm is significantly better than standard of care. The 5-day arm is not, although it doesn't look like there's much difference in the distributions here between the 10 and the 5-day arms. Looking at adverse events, basically the quick summary is there really was no significant difference in adverse events between the remdesivir groups and standard of care, slightly more in the 10-day group than in the standard of care group, but not when you look at grade 3 or worse events or at SAEs. In fact, SAEs were more common in the standard of care group, and there were no notable laboratory abnormalities that stand out as being potential flags for remdesivir toxicity. Now, in contrast to those studies, there's the Solidarity study, a very important study conducted under the auspices of the World Health Organization. And this study had many different comparators, and for the sake of this presentation, I'm going to focus solely on the remdesivir arms. Eligibility criteria were pretty liberal. You had to be a hospitalized adult with COVID-19. You could not have received any of the study drugs that were included in the randomization. The primary endpoint was a pretty crisp endpoint, in-hospital mortality. So they're not placing as much emphasis on improvement in disease category or in time to discharge, but those were secondary endpoints, including the progression towards mechanical ventilation or duration of hospitalization. You can see the age distribution here, as well as the requirement for respiratory support. About 10% were already ventilated, 2/3 had a requirement for supplemental oxygen, and 1/4 were not requiring any oxygen at all. There were about 2,750 participants who were randomized to remdesivir or the control for remdesivir, and after some dropouts prior to actual dosing, that ends up with these numbers here that were used for the intention to treat analysis. So what did the study find? No difference. There was absolutely no difference in terms of survival between the remdesivir and the control groups. Remember, we saw that when in the SIMPLE severe trial, those participants who got remdesivir were compared to a contemporaneous control, and it appeared that there was a survival advantage for remdesivir, but that was not in a randomized setting. Here in this study, in a randomized trial, there was no difference. And that was true when you looked across various subgroups, as shown in this forest plot. You can see whether in people under age 50 or over age 70, there's really no suggestion of any signal at all. Likewise, whether patients were ventilated or not ventilated, there is simply no difference in outcome. If you look at all of the remdesivir data in a meta-analysis that is included in this paper by the Solidarity group, what you see here is, and this is just focusing on mortality endpoint, not on time to clinical improvement. You see that overall, again, there is really no signal for a statistically significant benefit on mortality of remdesivir. So where does that leave us? Well, as a consequence of these data, the US Department of Health and Human Services guidelines panel for COVID-19 says that for patients with mild or moderate COVID-19, there are currently insufficient data for the panel to recommend either for or against the use of remdesivir in patients with a mild or moderate disease. For patients with COVID-19 who require low-flow supplemental oxygen, the panel recommends remdesivir for 5 days or until hospital discharge, whichever comes first, and that's a strong recommendation supported by strong data. That means that if somebody is well enough to go home, you don't have to keep them in the hospital to complete a 5-day course of remdesivir, and that's an important point. But for patients who are much sicker, for those who require oxygen delivery through a high flow device, non-invasive ventilation, mechanical ventilation, or ECMO, there's uncertainty regarding whether starting remdesivir confers any clinical benefit, and the panel cannot make a recommendation either for or against starting remdesivir in that setting. So in conclusion, Randomized clinical trials demonstrate the clinical benefit, that is, improved clinical status or reduced time to recovery, in hospitalized patients with moderate and severe disease in some, but not all, trials. There's no survival benefit in the trials conducted to date. The DHHS guidelines currently recommend use of remdesivir in hospitalized patients requiring low-flow supplemental oxygen, and trials of remdesivir in earlier disease, patients not requiring hospitalization, are ongoing and will continue to inform our use of this drug. Thanks for your attention.